our second kind of weekly update for the COVID-19 here at IHA. I want to thank everyone for joining us today. We have well over 300 people on the call. So would ask that you mute your phones. We have tried to mute all the lines, but would ask that you unmute if you are not speaking. Just a reminder that we will also be as far as asking questions, please type in the chat box for those that are logged in and able to see the slides. So our first presenter today, we welcome back Dr. Lindsay Weaver, the Chief Medical Officer from the State Department of Health. The floor is yours, Dr. Weaver.
Good afternoon, everybody. Thank you for joining me. I'm going to try and hit a bunch of high-level things. As you are probably not surprised, there have been several changes over the week, and we expect for some more changes and guidance to come. I do, if you can forward the slide, please. I do recommend everyone to sign up for the IHON Indiana Health Alert Network. That is the best way for us to get out the updated guidance, including our testing guidelines and recommendations. So if you could please sign up for that so we can make sure we can get you everything that's most up to date. Next. For an update for COVID-19 in Indiana, so as of now, we have 12 positive cases in Indiana. You can see what counties where we've had positive cases, and this represents positive cases that we have done at the State Department of Health as well as outside laboratories. So we will be putting whatever reports we get for positive cases up here, and it is up to date as opposed to midnight the night before. The way that we're running tests now is we are running them about mid-morning and expecting to get results late afternoon or early evening, and then we'll update these numbers as of then. Next. So as you know, the World Health Organization has declared this a pandemic, and we believe we are in the early phase of the outbreak. So our public health efforts are really focused on containing the spread of this virus and mitigating the impact of the virus. I'm sure many of you saw that the governor put out a press release with some information, including some information about school closures. Next. So for some interim guidance for healthcare facilities, I think that it's definitely recommended that we should be in the preparation mode for more things to come down the road. Everybody should have access to EM resources, and we ask that you continue to update that daily so that we can become better aware of what resources you have. Next slide. ISDH has now developed a provider-only phone number. Followed by pound. If you could please mute your phone. Thank you. So the provider number is going to be staffed 24 hours a day, 7 days a week at 317-233-4672. And I'm going to go with you over with you some updated guidelines for testing. That'll be important for your infection prevention leaders and for your providers to know. Next slide. So the new guidelines as of today, the Indiana State Department of Health has the ability to do the test to get back in a timely manner. We are limited on our ability to do that based on the number of tests that we have been given. Therefore, we are going to be running tests only at this time for patients that are requiring hospitalization with fever and lower respiratory symptoms that require admission to the hospital and are negative for other sources of infection such as influenza and RVP if available. We recognize at several hospitals that the turnaround time for RVPs is several days, and we don't want our providers waiting on getting the results of the COVID test because we know that PPE and isolation rooms are in short supply. Next. Next, thank you. Additionally, ISDH will be prioritizing testing healthcare workers, and that includes inpatient, outpatient, nursing home, et cetera. So those people who are symptomatic with fever and lower respiratory symptoms and in their role could have had the potential or unknown exposure to at-risk patients. We do know that we have a cohort of patients that are at risk for severe disease, and we also recognize that healthcare workers could possibly expose those patients. So they have been elevated where they would be a priority in running the test. Next slide. And that also includes long-term facility residents and residents of a prison and jail and the staff that is there, again, so that we can protect those that are most vulnerable in their current situation. Next. As many of you know, that there is opportunities for outside testing. LabCorp, Quest, we are getting notification that there are some hospitals and hospital systems that feel like they're going to be up and running, as well as other private organizations, hopefully here in the coming weeks. I did get to work in the call center last night and spoke to many providers, and a lot of them didn't know of the options at their hospital. So I would please ask you to make sure that your frontline knows of their capabilities for testing through ISDH versus testing in an outside lab. We would have providers consider testing patients who meet discharge criteria but are otherwise at-risk symptomatic individuals. And we also want to remind you to inform patients when they're getting discharged of the risk of having worsening of their illness about 8 days after the onset of symptoms, and that if you do use an outside lab and you get back the report that a patient is positive, that is reportable to ISDH. Next slide. Continue to communicate with your healthcare partners that right now the CDC is still recommending that when an NP and OP swabs are obtained, that be done while the provider is wearing a N95 or PAPR. We would not be surprised if CDC doesn't change these guidelines, so we are monitoring this closely. We also encourage you to use telehealth and nurse lines to have patients stay home if they have mild illness. And that asymptomatic patients at risk for COVID-19 that have had direct contact with the patient or traveled to a geographic area should be advised to stay home in quarantine for 14 days from the day of contact. And that for symptomatic patients with mild symptoms that do not require hospitalizations or for them to seek care, and they've had contact with a known COVID-19 patient, should be assumed to have COVID-19 and therefore do not require testing, but they do require the proper education on when to seek care and how to care for themselves at home. Next slide. We are asking of every hospital, if possible, that they develop a one-number system for us to be able to report results to. As you can imagine, we're getting calls from emergency medicine physicians in the middle of the night to give us our number. We get back results the next day in the afternoon, and it's difficult to track down who is the right person to call back this patient to give them a result, and also who's going to notify the provider who is well past their shift and interaction with the patient. So it's easier when the patients are admitted, but maybe difficult if patients have potentially been discharged. So if you can give us a one number, maybe you have stood up incident command at your hospital or the infection prevention specialist, and then that way that if a provider calls in and ISDH has determined that they do meet our criteria to test, that will give the epidemiologist a number to call back if they have further questions and follow up about contacts and exposures, and also someone to report test results to. Our ask is that when the hospital receives those results, we're going to ask that they report the results to the patient, since there has been a prior contact with the patient and a relationship made, and also that the report of the results gets to the provider, so that if there was any kind of breaches in exposure, that can be followed up at that time. New slide. We are telling providers, because we want to be able to streamline their conversations, and we hope with our with our updated guidelines that this will be easier for them, to have the patient's name and date of birth ready, as well as the one phone number, preferably, that can be called back by our epidemiologist at any time, and that person be aware of the case. We also ask that they have details of the case at hand, including if they've already had a negative flu swab. Next slide. So for testing for the virus, does require the nasopharyngeal and oropharyngeal viral swab and the viral transport media. We have heard from some hospitals that they are running low on these, and so that we have added that tab to EM resources. And so if you see that tab on EM resources, that's what we're referring to. We want to know if people are running low, and so we can do what we can help out. I would consider, if you are a hospital or hospital system associated with outpatient centers, that to look to them as possibly a resource for more kits. And it's also been advised to us by our lab that you could order the swabs and the viral media separately, and you may be able to obtain those easier than trying to order their kits. Next slide. Collection of respiratory specimens. So this is a change. Previously, CDC was recommending that obtaining the specimens be done in a negative pressure room. We do believe that this virus is droplet, and therefore the guidelines have changed, and they say that specimen collection should be and can be performed in a normal examination room with the door closed. They are still asking that the provider wear an N95 mask or higher level respirator, and that the number of healthcare providers present during the procedure be as minimal as possible. So essentially one person, if at all possible, and that visitors not be present when the specimen is collected. Next slide. Next slide. So we do believe the majority of the patients will be well, and so there has to be a plan for discharge, including a plan to give masks to the patient if available, and instructions on the latent 5 to 14-day onset of severe symptoms. As we learn more and more about this virus, we have heard that patients were not aware and therefore may have delayed coming in to seek care. We also want to notify the patient to call ahead to the hospital before they come in so that you guys can be best prepared to care for them. Next slide. I would recommend that you print off home care instructions for the novel coronavirus available on the ISCH website and have them available for your providers that will be seeing these patients. Again, in the call center, many of the frontline providers were not aware of this, and this is such an easy tool to be able to hand someone and go over all the instructions. Next slide. Discontinuing home isolation. So this also is a change. CDC it was recommending the 2 negative swabs before someone could be removed from isolation. At this time, we are going with what many other states have determined for discontinuing home isolation, recognizing that we do have to limit our testing capabilities. And so the recommendation is that the patient remain under home isolation precautions for 7 days or until 72 hours after fever is gone without needing to use antipyretics, and whichever is longer. So at least 7 days, and then it will no longer require the 2 negative swabs. Next slide. Alternative cares of plans. So we know of several hospitals and hospital systems that have quite remarkably stood up virtual care sites, nursing lines, telemedicine, and we just can't tell you how much that we appreciate your support and what you are doing for the people in Indiana. We do believe that has significantly helped us in our ability to communicate to patients, and so we would love for all of you to share that with one another, and I know that several of the hospitals and hospital systems have told us that they are available across the state. Next slide. If you advance one more time for me. Thank you. We do want you to continue to conserve your PPE, and also we do believe that we are in the reuse phase as well. Again, this is currently being monitored on EM resources. If we see where a hospital says that they're in the red, you will be getting a call from us to talk through exactly what your shortages are. ISCH has requested more from the national stockpile. We don't have any details exactly on how much we will get or when it will arrive, and we will update you as soon as possible, as well as with our plan on how we will distribute it. Next slide. Please, again, protect your healthcare team by advising home care when appropriate. If we can keep as many patients from coming into the emergency department as possible, that will allow our frontline providers to take care of the best possible care as we can. We've also heard of different companies or hospitals starting to work on standing up a mobile testing site using private labs. Next slide. This again is another update and different from last week. So recognizing that there is a shortage of PPE, the CDC is saying that face masks are an acceptable alternative when respirators cannot meet demand. And therefore, the goal is that available respirators are prioritized for procedures that are likely to generate respiratory aerosols. So that means in your typical care of the patient, so not intubating, not doing CPR on a patient, not doing a bronchial lavage, that the normal care of a patient can be done with the provider wearing a face mask. And that includes a face shield or goggles. And then to reserve the respirators for those aerosol-producing procedures. CDC does continue to recommend eye protection, gown, and gloves. Next slide. EMS is the same. They are also recommending just face masks in case you are getting questions from your EMS colleagues. Next slide. Negative pressure room update. Again, that patients with known or suspected COVID-19 can be or should be cared for in a single person room with the door closed. So before the recommendations said negative pressure rooms if available. So now the CDC is stating that a single person room with the door closed is acceptable. And again, to reserve those negative pressure rooms for the patients who are undergoing aerosol generating procedures. Next slide. We want to remind you that if you are using outside labs, that the positive tests are reportable to ISCH. Next slide. Recommendations for outpatient facilities. To begin planning to reschedule non-urgent outpatient visits as necessary. Consider reaching out to patients who may be at higher risk for complications and asking, and also for doing as much telemedicine for those patients as possible. Symptomatic patients who need to be seen in the clinical setting should be asked to call before they leave home so that the staff is ready to receive them using the appropriate infection control practices and personal protective equipment. And as mentioned before, a closed room with a face mask is determined appropriate as long as you are not doing an aerosol producing procedure. Next slide. For the inpatient facilities, so plan to reschedule elective surgeries as necessary and shift elective urgent inpatient diagnostics and surgical procedures to outpatient settings when feasible. It is recommended that you limit visitors to COVID-19 patients, and that is limit and not restrict. That the visitors will clearly have to be given proper instructions on how to protect themselves and to basically come into the hospital and go straight to the room, their loved one's room, and then to leave the same way. Also, it is appropriate to plan for a surge of critically ill patients and identify additional space to care for those patients, including cohorting the patients in a specific floor or wing of the hospital. Next slide. Very important to monitor your healthcare workers and ensure the staff are aware of sick leave policies and be aware of recommended work restrictions and monitoring based on your staff's exposure to COVID-19. As mentioned before, there's a nice table on the CDC website to help instruct on how you can advise your employees. As it becomes more spread in the community, it becomes ever more important to discuss with the healthcare personnel that they need to be monitoring for symptoms, even if they are not sure whether or not they came in contact with the COVID-19 patient, that every precaution needs to be taken that when employees are sick, that they do not come in contact with our patients who are the most at risk. Also important to make contingency plans with school closures so people can stay home when they're sick or care for their loved ones who are sick. Sorry, next slide. We have had reports of some patients who have been tested or were considering tested, that those have been leaked on social media. I think once again, this is ever important to remind your employees of HIPAA violations and how important it is that we maintain our patients' privacy and confidentiality. We also have heard several instances of providers being very anxious over the concerns over COVID-19. So whatever mental health resources that you have available for your employees, please take the time and effort to put that out there. Encourage your physicians and other healthcare personnel to talk to one another and to reach out with their concerns or if they're having any trouble. Next slide. Again, COVID-19 is it is asked that be reported on the death certificate. Next slide. So here again is our 24-hour provider number, 317-233-4672. Our goal is to hope to standardize better now that we are hoping that we're kind of in a different place than we were before with the expectation of community spread instead of the monitoring for the travelers and contacts, that we would be able to move past having to go through the process of calling and make it more of a direct line to test and get to the Indiana State Department of Health using the criteria of patients admitted with respiratory illness and a negative flu. But that is to come. We are still asking that they call and talk to our epidemiologists about testing capabilities. Next slide. Feel free to reach out to me if you have any questions. This is not my direct email, but they will get pertinent questions to me. And we're always appreciative of you letting us know what more you're needing to hear from us. I don't know, Andy, if you want me to take some questions.
The questions that were asked were items that you have already addressed. I think, so one question, point of care testing, is that how close have you heard our groups towards having more point of care options?
So we're hearing lots of things. I'm getting contacts and emails daily from different labs and businesses and hospitals that they are close, but I haven't seen anything definitive yet. I keep on hearing things like next week, mid-next week. So as we get that information, we will be sure to push that out to you when people are actually ready to go live.
Well, we just want to thank you for being so open and available for us to provide these updates. ISDH has been very upfront as far as providing critical information in a very timely fashion. And I would encourage everyone to continue to visit the ISDH website as well as the CDC on a daily basis with this breaking information as it becomes available. So switching gears, we will now turn it over to the several lawyers from Hall Render. A lot of questions that have come in regarding how to, kind of the legal aspects that the COVID-19 presents organizations. And so with that, I'll turn it over to Brian Bettner.
Thanks, Andy. Good afternoon. There's a handful of us that are going to speak on a broad range of issues. And as you appreciate from Dr. Weaver's discussion, it is a big subject with a lot of issues to address. One thing to keep in mind, there may not be an answer for everything you're trying to do. A lot of this is novel. Agencies and the interpretation of what you can and cannot do is evolving almost by the day. We are getting more clarity, though, because with the determination of a public health emergency and other activities, that should free up opportunities that were otherwise not there. Those are yet to be determined. For instance, I fully anticipate there will be requests from hospital associations, HHS regional offices, providers, et cetera, for Section 1135 waivers and a whole broad range of things that may be available. None of those have been issued yet, but the declaration by Secretary Azar yesterday of a public health emergency will allow that to happen. And so stay tuned. I want to point out that because there are so many resources in a lot of disparate locations, we have attempted to the best we can to aggregate those in one source. And so Andy Van Zee has posted up in front of you what we've identified as a resource center. So we've attempted to compile from all the various resources that may be pertinent to you where you can get to a one-stop shop, so to speak. And we will continue to update it, and we will add to it and add clarity wherever possible. But it covers everything from CDC to materials that we generate, articles that we've recently published specific to these things, various Medicare and Medicaid updates, state departments of health, so on and so forth. So we will continue to update it to the extent you have a relationship with us and you want us to add something. We welcome you forwarding that to us, and we'll do so. But feel welcome to use that. We will work then in concert with Brian Tabor and the team to make sure it has what you want in it. That being said, understand some of the solutions you may be pursuing, there's, as I said before, not a clear answer to. So the expression I use is there's a lot of square peg, round hole solutions. And so it's a matter of using your good judgment on whether it's permitted, whether it's in the patient's best interest, whether you can get billed for it, what do you do if you can't get billed for it, and all those sorts of things. So I'm going to pause there, and we're going to start with Melissa Markey is going to go over what we've received as some of the priority clinical questions focused from EMTALA, patient interaction, and so forth. Melissa?
Thanks. Thanks so much, Brian. And the only clarification I'd make is it's not changing daily, it's changing hourly. A couple of things to touch base on very quickly. There was a great discussion just a minute ago about PPE and CDC's guidelines. I just got off a call with CDC about 10 minutes ago. As noted, CDC has stated that except for aerosol generating interactions, surgical masks can be worn, save those N95 respirators for aerosol generating interactions. Centers for Medicare and Medicaid Services has stated that they've agreed and they have issued guidance that indicates that any survey activities will find that as long as you're following that protocol, you'll be found to be in compliance with survey guidelines. One of the things that CDC did discuss on this most recent call was that if you do have your respiratory patients cohorted in specific areas, you can move from patient to patient without changing your mask and eye protection. You do still need to change your gown and gloves, but as long as you don't have gross contamination, you can move within the cohort using the same mask and eyewear. It is considered much, much riskier. However, if you remove the mask and eyewear and then reapply them, they do not recommend that. That should be a sort of last ditch scenario where PPE becomes extremely low availability. We do note that OSHA, the Occupational Safety and Health Administration's position is under their respiratory protection regulations is that N95 is the required respiratory protection for, significant respiratory disease. They have not come out with new guidance yet, but I think that it's important to recognize that we anticipate that they will understand that you are following the guidance and the recommendations of scientific experts in this area when you do this. The other thing that CDC noted was that if you have N95 respirators that are past their use date as issued by the manufacturer, it may be possible to continue to use those N95 respirators, use them with caution, and preferentially use them for the lower risk interventions as opposed to those interactions that are very high risk for aerosolization activities. Next sort of big topic I wanted to touch base on is EMTALA. it is very important to recognize that when patients do come to your facilities, it is viewed as patients coming to the hospital for medical care, and that, you know, therefore it's important to comply with EMTALA and to offer them an appropriate medical screening examination to determine whether they have an emergency medical condition. The level of medical screening examination can be adjusted to the presentation of the patient, and the stabilization treatment is, of course, then based on their condition. One thing that was made clear in some guidance that was issued by CMS this week is that you can set up alternative screening locations either on campus or off campus. One of the things that CMS said in the guidance was that those alternative screening sites and the direction of patients to alternative screening sites sort of needs to occur, and redirection has to occur after they've been evaluated for an emergency medical condition. Obviously, when you have a respiratory virus like this, one of our goals is to segregate the potential respiratory patients from patients with other medical conditions. We have been talking with CMS officials about potentially modifying their guidance to allow us to redirect respiratory patients before they enter a common screening and logging area. And we're hoping that we will get some modifications on this guidance. At this point, though, do be aware that the current EMTALA guidance does require a screening and logging before you redirect. And so that needs to be considered carefully as you're setting up your alternative logging or alternative screening locations. The last thing that I wanted to talk about that I think is really important is remdesivir, which is an antiviral medication that is being used for some of the more severe COVID-19 patients. Is available through a couple of different pathways that you should be aware of. There are 2 open label clinical trials available for patients who are significantly ill and hospitalized. There is also an NIH trial that's called the Adaptive Trial. Those trials are listed on clinicaltrials.gov. If you're interested in participating in those trials, we're happy to help you get in contact and get set up with those trials. Also, Gilead, which is the manufacturer for remdesivir, is permitting limited compassionate use of remdesivir for patients who are seriously ill and don't qualify for the clinical trials. Typically, these patients are pregnant patients and some pediatric patients. So if you have patients that meet that patient profile, let us know and we're happy to assist you with that. And so that's a really fast clinical overview, and I will turn it over now to, who am I turning it over to? Brian?
John Rabin.
To John Rabin, thank you.
Thanks, Melissa. I'm going to cover some COVID-19 related issues from the employment law perspective. Obviously, COVID-19 is impacting healthcare organizations from as employers too. One big issue that's surfacing centers on the refusal by employees to come to work at all, or the refusal to treat patients who have been tested positive or who are suspected to have the virus. I want to touch first on the refusal to come to work at all. Some employees are just fearful, and whether for good reason or not, they don't want to come in. They're calling in sick, they're using PTO, and sometimes they have no paid time off left at all. Obviously, this is creating operational problems, and it will continue to do so, and it's going to create morale issues too, when the folks who feel like they have to come in resent the folks who aren't coming in. Most organizations have policies that require management to approve the use of PTO time. Because employees will be getting sick or getting quarantined, you may not have the flexibility to discipline or fire people who don't honor those policies right now. So what to do? This is a twofold response in my view. One is the communication piece. You need to ensure your employees that the hospital is taking all the protective measures it can. The things we know you're doing already: cleaning, filtered air, sanitizers at every desk, requiring personal protective gear and restricting travel and so on. We know you're doing those things, but it's important to communicate it to your employees just as you do to your visitors. As important as those things are from a public health perspective, that communication is also important to limiting the number of people who may want to stay home from work. The second thing is about defining priorities for discipline. You have the option to discipline employees for taking unapproved time off, but you have to tread carefully because you might not be able to afford to lose them. This is an organizational decision, and we recommend that you be consistent across the whole organization, or at least by the department, or by defining who is considered essential or non-essential. And before you issue any discipline for someone's refusal to come to work, the HR folks or management team should have a direct in-person or phone conversation with the employee about the reason they're not coming in. And why is that? Well, first, the employee's own medical condition might require an accommodation in the form of a leave of absence. In other words, the Americans with Disabilities Act might make you allow them to take time off. Take an employee, for instance, with chronic lung disease who can't be exposed to the virus. That employee probably needs to be allowed to take time off. If they've run out of paid time, you certainly have no obligation to pay them for their time off unless your policy otherwise speaks to it. Second, if the employee has a serious health condition, if you find out from this conversation, or they have to care for their own family member with a serious health condition, they might be entitled to leave under the Family and Medical Leave Act. The FMLA doesn't mean you have to pay them, again, unless your policy says so, but it does require you to continue their group health insurance benefits. Another reason it's good to talk with the employee to find out exactly why they may be taking time off is to expose whether or not this is simply a general fear. OSHA rules say that an employee doesn't have the right to walk off the job based on a generalized fear. And the Department of Labor today said that you don't have a right to FMLA leave simply because you're afraid or that you may be exposed to the virus. On the other hand, if an employee has a good faith belief that working in a hazard like the COVID-19 environment could lead to serious injury or death, you can't discipline them. All of that being said, this may be a time where you want to be more flexible with your time off policies. And I'm not saying you need to pay people for their time off if your policy doesn't require it. But in a public health emergency, the community at large and your prospective employees, the folks that you may want to hire 3 weeks from now, are not going to look favorably on you as an organization if you're firing people or disciplining them because they had to stay home with their child whose school is closed. So the approach to employees who are refusing to treat infected patients, that is the folks who are coming in but they're saying, I'm not going near that patient, should be similar. You need to have a direct conversation with the employee to determine the reason, and you need to ferret out whether there's a medical reason or some other legitimate reason that the employee is refusing to see the patient. And again, you need to determine your priorities from a discipline standpoint and what your organization philosophically wants to condone or sanction. So another category of issues that I want to talk about is what you can and can't ask your employees about their conditions and where they've been. For the purpose of determining whether to send a sick employee home, you absolutely have a right to know whether they've traveled and where, whether they've attended conferences and so on. And likewise, you can require that your employees answer whether they're experiencing flu-like symptoms. And you can even require them to take their temperatures. This is not ordinary situations, but In the face of a pandemic, I think it's legitimate to ask an employee to take their temperature. If it's job-related and consistent with the needs of your business, those medical inquiries are fair game. So one other thing to keep in mind about this is that a lot of nursing and unit managers and hospital leadership very cautious about HIPAA, and they should be. But when you're talking about your own employees that you're not treating, there's no real HIPAA concern about asking the questions. In your capacity as an employer, you can ask questions like that if it's for the purpose of determining whether someone should be at work or not. However, and this is a big however, once you get answers to those questions, once you find out information from a medical examination or an inquiry, you need to keep that information confidential. You can't send out an email within the department that says, Bob Smith tested positive for COVID-19 and you should all stay away from him. You need to keep that information confidential. And finally, the third issue I want to talk about is pay for people who were sent home. If you have a non-exempt employee, these hourly employees, do you have to pay them if you send them home? Generally, only if your policy or a union contract says you do. Of course, you want to make sure that you're treating sick people like you do healthy people that are sent home. If you have exempt employees, do you have to pay them when they're sent home sick? Again, it depends on the policy, but generally an exempt employee has to be paid for partial day absences. So if somebody takes off half the day because they're sick, you got to pay them for the whole day as an exempt employee. But if they miss whole days, you can dock them for their pay, but you do need to extend to them your sick leave benefits. So those are the employment law perspectives from the COVID-19, in the COVID-19 world. I'm going to turn it over to Sean Fahey, who's going to talk a little bit about SNFs and CMS guidance.
Thanks, John. As John said, I'm going to focus the next few minutes on skilled nursing issues that have been the topic of several CMS memos over the past few days. We know that many of you have skilled nursing partners and that everyone interacts with skilled nursing facilities in your communities. The topics I'm going to touch on are visitors and visitor screening and restrictions in those environments, as well as some transfer issues and admission issues in those environments, and end with the suspension by CMS of most of its survey activities. CMS it came out with a memo on the 4th of March, and then 5 days later revised it, recast it on March 9th. CMS recognizes that the regulations for skilled nursing facilities and the state operations manual allow facilities to restrict or limit visits to prevent community-associated diseases. And what CMS did in these memos was enhance its guidance to offer facilities some additional recommendations and directives on how they can screen and restrict visitors. So when those facilities are looking at screening and restricting visitors, CMS says that the facilities need to actively screen and restrict visitation by individuals who fall under at least 4 categories. If that visitor has traveled internationally in the past 14 days to one of the countries that has sustained community transmissions, and there's a CDC list of those affected countries. The next group includes visitors that have had signs or symptoms of respiratory infections. The next group are visitors who in the past 14 days have had contact with someone who's confirmed a COVID-19 diagnosis or has had contact with someone who's under investigation for a COVID-19 diagnosis or has had contact with someone who has a respiratory illness. The fourth category is if that visitor currently resides in or has resided in a facility or other community where community-based spreading of COVID-19 is occurring. CMS says even if your visitor passes that screening test, that the facilities can require that the visitors use PPE in their facilities. Now, CMS has also offered 9 specific recommendations to facilities regarding restricting visitors to prevent the spread of COVID-19. A facility can limit visitors if the facility is in a county affected by COVID-19. So as Dr. Weaver identified, there are 12 Indiana counties that would fall under that limitation opportunity. A facility can discourage visitors if the facility is in a county that has not been affected by COVID-19. Another CMS recommendation is that a facility should increase its visible signage at entrances and exits, offer temperature checks, and offer hand sanitizer as well as PPE for individuals who are entering the facility. CMS recommends that facilities ask visitors if they've taken any trips within the last 14 days on cruise ships or participated in settings where crowds are confined in small common locations. When a facility allows a visitor, the facility should instruct visitors to limit their movement within the facility. CMS also recommends that facilities review how they're interacting with volunteers, with vendors, with agency staff, with transportation companies, and similar operators to make sure they're taking the necessary actions to prevent potential transmission. It also emphasizes that facilities should offer alternative means of communication to families and people who would otherwise visit the facility. This can include phone calls or video conferencing. CMS also suggests that skilled nursing facilities, when they do allow a visitor in the facility, suggest that that visitor limit their physical contact with the resident or with others while they're in the facility. And finally, CMS identifies that a facility should advise a visitor who's been in contact with a COVID-19 diagnosed resident prior to admission to that facility that those individuals need to monitor themselves for signs of the illness. Now, shifting over to issues that CMS also provided some direction on when facilities suspect that a resident it has in its facility has COVID-19. CMS highlights 5 different elements to consider. The facility needs to contact the local health department. If the symptoms are mild, CMS directs that the facility can keep the resident at the facility rather than transferring the resident to the hospital, as long as the facility can follow the CDC infection control recommendations. The facility also, if the resident develops more severe symptoms, should transfer the resident to the hospital for a higher level of care. But prior to transfer, it needs to alert EMS and the receiving provider to the diagnosis, and also take precautions involving the transfer, specifically including a face mask on the resident during the transfer. In situations where the resident does not require hospitalization, the resident can be discharged home after consultation with the state or local public health authorities, and if it is deemed medically appropriate. CMS does direct that pending transfer or discharge, that a facility place a face mask on the resident and isolate the resident in a room with a closed door prior to that transfer or discharge. Shifting over to issues related to accepting a resident who has a diagnosis with COVID-19 from a hospital, facilities can accept an individual diagnosed with COVID-19 from a hospital, provided that the facility follows CDC guidance for transmission-based precautions. CMS says that if a facility cannot follow that CDC guidance, the facility must wait until the precautions are discontinued, so they would have to pause on that admission. CMS directs that facilities should admit any individuals that they would normally admit to the facility, including individuals from hospitals where a case of COVID-19 was or is present. And if possible, those skilled nursing facilities should dedicate a unit or wing exclusively from any residents coming or returning from those hospitals. So we are urging our skilled nursing providers to pull out their visitor policies and enhance them with these CMS recommendations. Typically, the visitor policies do not provide this much extensive detail in what the facility can do in monitoring and limiting visitors in its facility. I'm going to shift over to the CMS memo on the suspension of the survey activities. So on March 4th, CMS issued a memo where it suspended non-emergency inspections across the country. The goal by CMS was that inspectors focus on infectious diseases and abuse. On March 11th, it issued a frequently asked question memo related to questions that have been raised by surveyors as well as providers. One important note on this is that CMS has directed the state survey agencies to limit their survey activity to a specific group of issues in the following priority orders. The first priority is they will continue to inspect and survey all immediate jeopardy complaints as well as allegations of abuse and neglect. The second element they will continue to look at is complaints alleging infection control concerns, including facilities with potential COVID-19 or other respiratory illnesses. They'll continue to survey and inspect for statutorily required certification surveys for skilled nursing facilities, home health, hospice, and immediate care facilities for individuals with intellectual disabilities. The fourth prong is revisits necessary to resolve current enforcement actions. The fifth prong is initial certification. The sixth prong is surveys of facilities that have had a history of infection control deficiencies at the immediate jeopardy level in the last 3 years. We'll also continue to survey facilities and centers that have a history of infection control issues, as well as facilities with deficiencies at lower level than immediate jeopardy. These surveys are going to look a little different. The CMS memo instructs that much of the survey activity occur off-site, which would include interviews conducted by phone, reviewing medical records as much as they can off-site, and reviewing QAPI programs and other governing body issues related to that. They would also direct surveyors to be off-site in drafting their final documents. So what we're telling our providers is that they should expect to see fewer surveys unless they fall under one of these 8 magic categories, and that they should expect these surveys to look different than they have in the past, with much more activity occurring off-site. So now I think we're ready to open the floor for general questions.
Yeah, so we have a few questions as far as, does the facility have to take a patient back that has been referred, regardless of the COVID status?
I would suggest that they look at their discharge policies and the reason for the discharge. You still have to follow under one of those for skilled nursing facilities. There are 7 specific reasons as to why you can discharge your resident from your facility, so you should still fall under those elements.
Couple questions about the visitor policies, more around hospitals. So, can a hospital restrict visitation even if there isn't an active COVID patient in the community?
I'll take that, and Melissa may have some comments as well. So presumably their visitor policy contemplates communicable disease protocol or something along those lines. So as a practical matter, yes, but you'd want to be clear on was it arbitrary? Was there any kind of rhyme or reason to it? But as a general rule, because if you want to be consistent with CDC guidance, which contemplates the isolation process and separate entrance process and how you manage that, it would be prudent. But just from a PR and public relations standpoint, they want to have a consistency communication plan for how that's conveyed and how individuals are selected.
And so how would you recommend that hospitals look at the governor's orders yesterday as far as recommendations to hospitals and nursing homes and incorporate that into the current visitor policies?
Let's speak from nursing facility.
From a nursing facility perspective, I thought that the governor's directives were fairly close to the CMS guidelines, with exception of restricting the, access to anyone who's less than 18 years of age. I would recommend that communication with the residents and their families in a skilled nursing facility is critical at this time, so that they work to quickly revise and update their visitor policies to reflect the steps and actions that they're going to take and communicate that to their families. And blend in the additional requirements that the governor has identified.
So, first and foremost, go ahead, Melissa.
I was just going to say, you know, I agree that I think one of the most important components of this is extremely clear communications with your community so that they understand the reasoning for and the importance of the restrictions, and so that you mobilize your community to support your actions. I think one of the things that may also be helpful for all of us as we're working through this is that President Trump has just announced, he's just declared a national emergency under the Stafford Act. And I think that the declaration of a national emergency not only brings to our response efforts some additional tools, but I think it will also help clarify for some of our community members the challenge that we are dealing with, and it will help them better understand that this is a challenge that the entire community can help us address, and will help address some of the lack of understanding that the public has had about the severity of the disease and our response.
Most Indiana hospitals have close relationships with community partners such as local newspapers, local radio stations, those sorts of things. Your first line of defense is not the signage so much as the door. It's the communication plan with the community in terms of whether to come to the hospital or not. And so that may be an appropriate vehicle to kind of communicate in an appropriate fashion community members' relationship to the hospital and whether they should visit. Signage, critically important. Signage outside, signage at the receptionist, signage at nurses' stations, exiting elevators, et cetera, that makes it abundantly clear that really it's pretty much a need to know, need to visit, what the protocols are, encourage people to be mindful before they visit.
So a closing ask, I guess, the folks of Hall Render. A lot of folks are interested in more information around the kind of refusal of patients being transferred back to SNFs or external facilities. So any resources or blog posts that you would be able to put together for that, I think would be useful.
Who otherwise don't present at the ED, right? Yep.
So we'll move on just a couple more items before we close. So, just kind of wrapping up on a couple of the items that Dr. Weaver mentioned, EM resources. So we still have 31 of the 135 acute facilities in the state that are needing to enroll in that. We have been doing outreach to those organizations with hope here in the near future to get the rest of those facilities onboarded to this information. We still need, of the 104 that are actively enrolled, 25 of those as of this morning at 10 a.m. Still needed to provide an update. It was outside the 24-hour window. The state is looking for this information to be updated by 10 a.m. each day, so would encourage you to do so. You can see just a couple screenshots of kind of the dashboard showing the current, as of 10 a.m. this morning, the bed availability and some of the resource availability, as well as some of the growing PPE concerns. Earlier this week, I believe as of Monday, the critical number of facilities was at 4. As you can see, we've moved to 15, and so there is a growing concern around the PPE supplies around the state. Also, we sent out a survey to all hospital CEOs requesting information for the points of contact, as well as several initiatives that your organizations are undertaking with respect to the COVID response. Mutual aid agreements. So this is an item that when we came out to the district meetings this last quarter, asking organizations to update the mutual aid agreements. We have received 14 of those so far, and would ask organizations to update those and send them to myself. And just as a reminder, we will be sending out these slides to everyone that has registered for this call, as well as you can reach out to either myself or Karen Kennedy and Annette Handy with our quality and patient safety team. I want to thank everyone for coming on the call today. We plan to hold these calls weekly on Friday afternoons, and so we will be sending out information as to how to register for next week's call. Please reach out with any questions, comments, or concerns. IHA is here to help serve your needs and address anything as we move forward in this ever-evolving time. Thank you, and have a good rest of your day.